Okay, so I thought we'd talk about a few things today. We review some of the ICU outcomes that have been published in case series up until this point. Specifically, I'll talk about a study that came out recently with respect to CPR in COVID, and then talk about our own local regulatory situation with respect to the CPSO and what we do in Ontario regarding CPR. So I'm going to talk about the Seattle, Washington, Italy case series, and specifically because the ones out of Wuhan so far are hospital-based, and I thought for this audience, intensive care unit specific would be more applicable. We'll talk about the China CPR study with respect to the outcomes, and then I'll provide an overview of our regulations. So this is the first study that was published in mid-March, and it was specifically with respect to Washington State, where the initial outbreak in the United States was the most prevalent. So a few comments about this study. First of all, it was 21 patients, which is fairly small for a case series, but that was what they had at the time. And I'm showing you this this first table just to sort of point out a few things I think we already know. So this was their table one. It showed that they had the majority of patients who had comorbidities were things like COPD, congestive heart failure, diabetes, and CKD. And that's not surprising in terms of folks who get respiratory illnesses and end up in the ICU. We know that comorbidities are predictive. The other things I wanted to point out here, if you go down to the second facet, which is admission symptoms, fever was only present in 11 of the 21 patients. And even shortness of breath and cough were not in the 90 range, which we'd seen in some other studies. So some of these patients can present somewhat deceptively minimal in terms of symptoms. And the other thing that's interesting and was echoed other places is that the white blood cell count is 9 with a lymphopenia, so a low, on average, low lymphocyte count. In terms of the outcomes they saw in this Washington State study, remember again, this is 21 patients. About 57% had severe ARDS, which would be a PF ratio less than 100. Their admission PF ratio, sorry, their admission PF ratio was 169, and the nadir, or the lowest value on average, was 108, but obviously ranging there, you can see between 58 and 247. They used BiPAP in 19% of patients. They used high flow in only 1 patient, and 15 of the 21 required invasive mechanical ventilation. Some of the other statistics there, you can see the number of hospital days prior to intubation was low, so 1.5 days. They used proning in about half the patients, and they used inhaled ibuprostanol, which we don't use as much here, but something similar to nitric in 31%. Thought it was interesting that the rate of co-infection with bacterial or viral etiologies was low, so only a few patients in each. And they had a fairly low outcomes in general, but their acute kidney injury was only 4 patients. They did have quite a bit of cardiomyopathy, and this was defined as a new EF that was less than 40%, or evidence of an acute myocardial infarction. Then in terms of their outcomes, they had 11 patients die, which they're quoting there as 52% mortality. But the caveat to this is the third point, where 8 of the 21 patients remain mechanically ventilated. So that number will likely be higher. And only 2 patients out of 21 were transferred out of the intensive care unit. So this study, where almost half of the patients were still critically ill and mechanically ventilated, gives us some insights, but may not be the whole picture. This was a second trial that was published in Seattle and had a few more patients. So you can see there, this is the same table 1 at the top. There were 24 patients, so a few more. The male predominance was 63%. The BMI, which we've heard about as well in terms of this affecting patients with obesity more severely, was 33. In terms of comorbidities, they sort of reference their chronic kidney disease again, diabetes, and they did not have any patients with dialysis, but certainly CKD. In terms of their mean duration of symptoms before admission, you can see there it's 7. Once again, this study showed, if you go right to the bottom, that only 50% of patients had a temperature that was in the febrile range. but more patients here had cough and shortness of breath. In terms of travel history, I think this probably echoes what our current understanding is, that not everybody had traveled to a country where COVID was endemic in the last 3 months, and only half the patients reported a sick contact. In terms of their outcomes and what they did, I've sort of broken this down into 2 charts. They used high flow in 42% of patients. They did not use CPAP. 18 of the 24 patients were treated with invasive mechanical ventilation. 30% were prone, 40% had neuromuscular blockers, 28% had inhaled pulmonary vasodilators. They did not use ECMO. Most patients were on vasopressors, not surprisingly, and they did quite a bit of echocardiogram. However, they had no patients with new LV dysfunction. And what the Seattle group included, which I think is interesting, is the characteristics of mechanical ventilation, which is shown in this chart here. So 77% of patients had quite a bit of secretion. And I'll sort of summarize that they have the day 1, 2, and 3 median values for plateau pressure, driving pressure, the highest FiO2, and the compliance. And what I think is interesting, on all 3 days, their plateau pressures were well below 30, which is our target, but on average, they're 25, 24, and 22. Their compliance was also reduced, so 29, 26, and 37, but not terrible. Certainly not as high as some of the other groups have reported, especially in Italy, with compliances around 50, but a compliance of 37 by day 3 is not horrific. And also the FiO2 on day 3 was about 60%. So these patients were relatively compliant and not as hypoxemic as we otherwise see in other patients. In terms of their outcomes, you can see here that the number that died in the hospital were 12 out of 24, 50%, and 5 were discharged. So there were still patients who were there in the ICU and mechanically ventilated. So again, this outcome was probably a little bit on the underside, but they report 50% mortality. And the largest study that we have is from Italy, which is slightly covered by my box there. And this was 1,591 patients who were admitted to the ICUs in the Lombardy region of Italy. This is a similar likely health system to ours in terms of resources. And what it showed here, slightly obscured. So we have 1,591 patients, predominantly male. So in this study, it was 82% males. In terms of comorbidities, you can see their hypertension, cardiovascular disease, dyslipidemia, and diabetes were common. Chronic kidney disease was fairly uncommon. And then in terms of the respiratory support, 1,150 out of 1,591 patients, or 88%, received invasive mechanical ventilation. 11% were non-invasive, which would include high flow. And only 1 patient was in the ICU with just oxygen by face mask. The median PEEP was 14 centimeters of water, and the FiO2 was 0.7. So the median PF ratio was 160. And you can see here, similar to the other 2 trials, they proned about 30% and had ECMO in 1% of patients. This is a figure showing the distribution of a variety of parameters by age. So in the top left corner, I guess I would just bring your attention to the fact that many of these patients were not at the extremes of age. So there were many patients who were not elderly in the sort of 58 to 70 range who were admitted to the intensive care unit for COVID. The PF ratios also are right skewed, but do have a lot of patients in that 75 to 125 range at the bottom left of the screen. The FiO2s varied quite a bit. And then in terms of PEEP, you can see the majority were on a fairly high amount of PEEP in the general context, but really not that high in terms of ARDS. In terms of outcomes, again, 1,581 patients. So 405 died, and they quoted a mortality of 26%, but only 256 were discharged from the ICU. So most patients were still in ICU. And if you count those patients who were discharged either alive or dead from the ICU, the mortality was in the 65% range. They also subdivided it by patients with and without hypertension, and not surprisingly, those patients with hypertension had a higher mortality. So this is just a summary of, I think, the very pertinent facts to intensive care units that in the 3 studies, so Washington State, Seattle, and Italy, the ventilation requirement of those patients was in the 70 to 88% range. Mortality was, I would say, probably between 50 and 67%. And I put an asterisk beside that 26%, which I just addressed. And the rates of acute kidney injury and cardiomyopathy are not entirely clear right now from the available data, but we anticipate this will become more clear with time. Now, the other thing is that our local researchers, John Basmaji and Kimia Honerman, are completing a case series of our own experience, and we're hoping to have data to present at some point soon on that. So the second thing I wanted to talk about was the cardiac arrest and CPR data. This is a pre-proof from the journal Resuscitation, and you can see the title there is In-Hospital Cardiac Arrest Outcomes Among Patients with COVID-19 Pneumonia in Wuhan. So this was the Wuhan Union Hospital, which is a tertiary teaching center. They follow the ILCOR and American Heart Association guidelines for cardiac arrest, so similar to what we would do with ACLS. And they looked at 136 patients who had in-hospital cardiac arrest. In terms of the demographics, the majority were over 60 and the majority were men. Comorbidities echoes what I've just been talking about, that hypertension, diabetes, and coronary disease were the most common. In terms of the etiology, they found that 88% of the etiologies were respiratory in nature. And of all the rhythms, asystole was about 90%, with VT-VF being 6%. Something that I think is unique potentially to their experience was that 83% of their patients were monitored or were on the ward, and of those, 93% were monitored, which is likely higher than we would have in our ward patients. And the time to CPR was less than 1 minute in 89% of patients. And I think this is relevant because as we're talking about cardiac arrest outside the ICU and having protected code blues, in Wuhan, my understanding from what I've been able to read was that the providers were in the room the whole time in full enhanced PPE. So that explains their low time to CPR, but I anticipate in our ward-based patients, this would be higher, or a longer amount of time rather. In terms of their outcomes, they had return of spontaneous circulation 13%. At 30 days, 3% of the total cohort was alive. And of those patients who got ROSC, so of that 13%, about 22 were still alive at 30 days. And they don't break down their cause of death or the situations around withdrawal of life support versus natural death or multi-organ dysfunction. In terms of the outcomes based on the rhythm, you can see there that of the VT-VF cohort, which was only 6% of all arrests, they had 6 of the 8 patients achieved ROSC. In the asystole cohort, not surprisingly, only 11 of 122 had return of spontaneous circulation. This is, I think, the most glaring piece of data that came out of this trial, which was that a favorable neurologic outcome, which was defined by the cerebral performance scale, which we use here, was 1 out of 136. And their overall mortality in severe COVID was 19%. So this sort of leads me to the third part, which is what, in terms of our physician group, how are we approaching this, this situation? You can understand that patients with this level of expected recovery, as well as presenting the risk of CPR and intubation being an aerosol generating medical procedure, we want to make sure that we're giving consistent advice to our patients. And so a document came out from our College of Physicians and Surgeons of Ontario in the fall, which you can see titled there, and it concerns end-of-life care. Now, there are a lot of components to this document. It's publicly available, but I'll skip to sort of the meat in terms of what we are governed by in the section that's titled Potentially Life-Saving and Life-Sustaining Treatments. So a lot of words there, which I apologize for, and that's a huge faux pas in PowerPoint, but this is the most important component. So the point 14 says, physicians must not unilaterally make a decision to withdraw life-sustaining treatment and must obtain consent in order to withdraw life-sustaining treatment. So in patients in whom they're already receiving invasive life support, they cannot be unilaterally withdrawn from that treatment. The second important point here is that physicians must not unilaterally make a decision regarding a no CPR order. So this is a medical no code or a DNR without the patient's involvement. So it states in point A that before writing an order, physicians must inform the patient or SDM that the order is written and why. Point B says if they disagree, then the physicians must engage in a conflict resolution process, which is institution specific, and they will not write the CPR order until the conflict resolution is underway. And then very importantly, the third point, if the patient has an arrest while the resolution is underway, the physicians must provide all resuscitative efforts required by the standard of care, which may include CPR. So the way in which this is being interpreted is the physicians, if they feel that CPR will offer no reasonable benefit, inform patients and their SDMs. If there's disagreement, then we'll go through a conflict resolution process. And in the interim, they would be assessed for all resuscitative efforts at the time of a cardiac arrest. So in the event that they have pulselessness, the expectation is that the physician would come and assess, see if there is a reversible etiology or something that they could rapidly respond to, and provide whatever therapy they deem necessary, which may include CPR. The final thing I wanted to talk about is what we'll potentially move on to. So that is the current framework. I'll just skip back to that. This is the current framework we're operating under at this time. However, in anticipation of potentially larger volumes of patients and moving to a situation where we do not have the resources to provide what we would have traditionally deemed the standard of care, the CPSO and the various institutions are making a pandemic triage protocol, which is still in development, and Dr. Arnfield and Dr. Sibbald, Rob Sibbald will be talking to us about hopefully in the near future. So I'm not going to get into the specifics of what they'll talk about, and the final protocol, that to the best of my knowledge isn't finished, but it's largely informed by this study, which was published. It's publicly available from the Canadian Medical Association Journal back in the 2000s. And this was published sort of in the wake of SARS or afterwards, realizing that if we get to the point where we need to start triaging who would benefit most from therapies, it's best to have agreement among large groups of people and identify it in advance. So these would be a lot of the criteria that we would use to, as you can see there, exclude patients from admission or transfer to critical care. So I won't read through all of them. A lot of them make sense. And this would potentially be triggered in the event that we have exceeded our capacity to take care of the patients we normally would. And in general, all of these are situations in which the expected recovery is very poor. Understanding that if a patient has a respiratory etiology as their arrest, an asystole or PEA from COVID, the likelihood of a positive neurologic outcome is already extremely low. So you can see here things like unwitnessed cardiac arrest, witnessed cardiac arrest not responsive to electrical therapy, so that would be asystole and PEA, severe cognitive dysfunction, untreatable neuromuscular metastatic malignant disease, etc. So those would be the criteria that would largely inform our triage protocol, but as I mentioned, that's still in the works, and hopefully we'll hear more about that in the near future. So those were all of the slides that I'd prepared. Maybe if we can go to anybody who has any questions, and I'd be happy to answer as best I can. If anybody's on the computer, maybe they can type in questions first. So the question was, what article is that from? I'll post it. I can post on the Facebook group. It's from the Canadian Medical Association Journal, 2004-2006, and it's got the words pandemic triage protocol in it. And like I said, this is not officially what is exactly being used, but it's going to likely very closely approximate it. Oops.
Hey, Paul, it's Dave Nagpal. I'm here with the whole CSRU team. Can you just go back one slide to that slide about where we can, have some guidance on who? So just so that we're all on the same page, in the context of pandemic resource planning, CPSO is defending us when we make decisions on who we provide CPR to and who not. But as you said, so far, there's no explicit document or guideline that says, as a broad sweeping statement, that acute resuscitation for arrests in COVID patients are a contraindication to resuscitation.
Yeah, to the best of my knowledge, no. I think that the CPSO would sort of engage in this pandemic triage situation once we've reached a certain capacity or overcapacity, once we've really got to our surge capacity. And then it would be sort of more defensible. I think that the language that I've read is that there's going to be an awareness, and they're going to take into account the circumstances of COVID and where we're at in terms of adjudicating responses. But as far as I understand, and from everything I can gather, we're still operating under the most recent CPSO guidelines from the fall. So I don't see any other questions from the chat, but please text them in. Does anybody on the phone have any questions or comments?
It's Ravi, yeah. Paul?
Yeah.
So do I take it that CPSO is working on a document that will be made available?
Yeah, that's my understanding. I think that it's in draft form, and that it'll be sort of more formally presented to us and the region when it's completed.
Okay, great. And if you hear of it, you'll send it to everyone?
Yeah, for sure.
I wonder if Rob Sibbald is on the line.
This is Claudio. It's been in the media, or part of the media has gotten hold of the draft. I was very able to have seen, I saw some reference about it being released, but I haven't been able to find any publicly released version of it. It is, it's actually quite more extensive than the, like I have seen a draft of that. It's quite more extensive than what's shown on this slide. It's a very bit more granular. Age is not at all in it. Like I agree, it's and the framework behind it's quite. It has some face validity, and appears reasonable to us. Of course, without anybody having, and a lot of people not having seen the actual draft and speaking out about it, there's a bit of debate. Unfortunately, better informed that they actually just released it to the public and allowed people to properly debate it. But that's all I know of it at the moment.
Yeah, exactly.
Paul,
I think it's still in development, but sorry, go ahead, Murat.
This is Murat here. Hi, guys. I just wanted to pose a question to the audience. Do you guys have any specific worries or concerns about performing CPR? Let's say we have a COVID suspected patient or a COVID positive patient in one of our ICUs, goes into cardiac arrest. Do you guys have any specific concerns or anxieties that we can chat about?
Hey, Murat, it's Dave. My approach here would be if a COVID patient arrests and the airway is secured and the chance of aerosolization is reasonably low, I think well-protected healthcare providers, I'm comfortable saying, acute resuscitation would be reasonable. You know, it's funny, just a little while ago, we were talking about how we actually have